mitochondrial protein folding, unfolding, and degradation of poorly folded proteins, I think. Reminder that the first exam is a week from today. There are 3 options. You can take the exam at 10:30 in this room. You can take the exam at 1 o'clock in the lab, or you can take the exam at 7 o'clock in the lab. You don't have to be in the 7 o'clock lab to take it in the 7 o'clock lab. But those are the 3 options for taking this exam. If you I know that Lindsay and I have a overlap with microbiology. If you want to try to talk Lindsay into offering it on another day, that's up to Lindsay, but I'm offering it morning, afternoon, and evening. Let's see. In lab today, we will do a case study. We'll do 2 case studies of coronary artery disease and heart attack. So, and I'll show some interesting diagnostic images that I was able to get. So we're not going to do dissection. We're not going to work on animal parts. But today we'll work on a case. 2 cases actually. 1 case is actually a friend of mine. So personal involvement. And so today we're going to do a quick review of the Wiggers diagram, which is an important sort of a way to assimilate your knowledge about the heart. And then we're going to get outside the heart and start to talk about the vascular system, the other important part of the cardiovascular system. And so we'll talk about some important equations related to blood pressure. The heart, you think about the heart as maintaining blood flow, and that's important. But maintaining blood pressure is important too, because it's the pressure that creates the flow that is necessary to sustain the organs that receive the blood. So we'll talk about the control of blood pressure and the control of blood flow to the various parts of the body. That's where we're going today. Okay, so here is the Wiggers diagram from your textbook, which is hard to see. But let's go through these questions. And these questions are not meant to test you. I'll test you next week. But they're meant to get a conversation going, right? By me asking you a question, trying to provoke a question from you in order to clarify something that you might not understand. So, what events mark the beginning of atrial systole? And I'm not doing this as a clicker, I'm doing this as a conversation. So somebody tell me, there's more than one thing you can look at on the Wiggers diagram to mark the beginning of atrial systole.
So after the P wave is happened and the blood volume in the ventricle is high.
Okay, so here, why don't you point? This is a sharp laser, a bright laser. Point to what you're looking at.
So volume is high.
Okay, so I will accept that answer, especially this transition right here. This small increase in ventricular volume is evidence that the atria have contracted and pumped some blood into the ventricles. Okay, there's another answer. Are you willing to let Mackenzie answer again? Oh, I see some hands over here. Mackenzie, I'm going to answer. Tynan, show me on the Wiggers what event marks the beginning of atrial systole. The P wave.
Yeah.
The P wave is the electrocardiogram marker of the beginning of atrial systole. The PR interval is the duration of ventricular systole. But the onset of ventricular systole, which is what the beginning, would be marked by the P wave. Question, Michael? Or do you have another point you want to point to?
I think you,
What, did I say something wrong? The P wave represents the beginning of atrial systole.
yeah, you said ventricular.
Okay, sorry. P wave, I'm sorry. P wave represents the beginning of atrial systole, and the PR interval represents the duration of atrial systole. Apologize. I usually get left and right mixed up. I don't usually get atrial, atrial and ventricular mixed up. Those are two good answers. You could also say this little blip here in pressure. That would be another marker of atrial systole. Okay, then let's go to the next one. What events mark the beginning of ventricular systole? Now we're talking about ventricular systole, the beginning of ventricular systole. Matt?
The focal point. The QRS complex.
The QRS complex represents on the electrocardiogram the beginning of ventricular systole. There's more.
I think that this line is ventricular pressure, but the sharp increase.
But if you measure pressure, a sharp increase in ventricular pressure represents the beginning of ventricular systole. The isovolumetric contraction, rapid rise in pressure, represents the beginning of ventricular systole. Okay, that's another correct answer. There's one more good answer. Brittany?
Sound oil.
Right, the first heart sound, the closing of the AV valves. Okay, I'll leave it out there, so, because we're going to do the next one. When does ventricular ejection start? Brittany?
After
Get the laser. See, what are you looking at?
after the point, where the, ventricular systole starts and the volume starts to drop.
Okay, right, so we could look here and say ejection starts when the volume starts to decrease. That's a good answer. You just had two things, right, though? Was it, do we see when ejection would start on the pressure curve? So this is pressure, this is volume, this is ECG, this is sound. Brand.
When the pressure the ventricular pressure overtakes aortic pressure.
When ventricular pressure exceeds aortic pressure, ejection will start. Right? Questions? Pressure, volume, ECG, sound. X-axis. Okay, what events mark the end of ventricular systole? Ivan, is that a partial no? Joey?
The T wave from the.
Okay, on the ECG, the T wave mark is the electrocardiographic marker of the end of ventricular systole. Lawson? Sound two, the closing of the semilunar valve represents the end of ventricular systole, the beginning of the isovolumetric relaxation. sound. Michael? The beginning, the end of, so the end of systole would recommend when you are at end systolic volume or at end systolic pressure. Sort of, this point right here would be the end of systole, because this is now the beginning of diastole. Okay, those are good. When does ventricular ejection end? Matt?
Aortic pressure overtakes ventricular pressure.
Yeah, when ventricular pressure falls below aortic pressure, then ventricular ejection ends. So I could ask you, these are the kinds of questions I could ask you on a test. Interpret the Wiggers diagram. Yeah.
So we won't have to memorize this, you'll like give it to us?
Oh, I
and
will
we'll
not
have to-
ask you to reproduce
Okay.
the Wiggers diagram. I would give you the Wiggers diagram, or I could ask you these questions and expect you to have this image in your head. You might need scratch paper to sketch it out, but I will not ask you to create it.
Okay.
Did that answer your
Yeah.
question? I would not ask you, say, draw the Wiggers diagram. I wouldn't do that. But I could ask you any one of these questions or similar questions even without giving you the Wiggers diagram. If I said, where on the Wiggers diagram would you look for to see when ventricular ejection ends? You would say, well, I would look at the pressure curve and I would find when ventricular pressure fell below aortic pressure. That would be in words what you were looking for. I would like you to be able to translate this graph into words, because translating it into words is what indicates comprehension and not just memorization of this point, this point, this point, this point. Does that answer your question? Hmm?
For the problems, what do you mean by schematic diagram?
Oh, yes. So this is now an aside. So this has to do with the problem set. In the problem set, which is due on Sunday, thank you for this reminder. Problem set is due on Sunday. And the problem set is geared to help you understand the ECG and use use the cardiovascular anatomy. But the last question asks for a schematic diagram. What do I mean by, I'm not asking you to trace the coloring book. I'm not asking you to be an artist, because I sure am not. But a schematic diagram. So what's that a schematic diagram of? What's that a schematic diagram of?
Pulmonary artery.
Okay, I gotta give you a better hint.
Yeah.
So now what is it? The aorta. That's a schematic diagram of the aorta. Then we know there are three things. There's a schematic diagram of the three things that come off of the aorta. And here's a schematic diagram of what the aorta branches into, the pelvis. Oh, by the way, in order to answer this question, you need the coloring book is helpful, but the coloring book assignments got a little out of sync with the quiz, with the problem set assignment, and you have to go to next week's coloring book assignment. I forget what pages it is in the schedule, but next week's coloring book assignment gives you some answers to this schematic diagram. And it's just as well to start looking at next week's coloring book to start assimilating that information for the exam. And so you'll do something like this. And you might, we'll see in class today, in lab today, the coronary arteries. And you'll see that there are two coronary arteries that branch off from the aorta and feed the heart muscle itself. So that would be a schematic, and as long as it was labeled, aorta, right coronary artery, left. I'm going to stop giving you answers because this is what I'm saying. Is that clear? Yes, Grant.
Will you cover volumetric contraction
Sure. So isovolumetric contraction is when the ventricular muscle has started to pump, has started to contract. That contraction closes the AV valves, but the pressure is still below the aortic pressure, so the aortic valve has not yet opened. So the heart is closed. All the valves are closed, and yet it's starting to contract. So isovolumetric, the volume can't go anywhere. Isovolumetric, the volume can't be changing because all the valves are closed. The heart is closed, but pressure is increasing. Isovolumetric. So we can see that here. No change in volume, but a big change in pressure.
Right.
Isovolumetric relaxation is when there is no change in volume, but there's a big change in pressure. This is after the heart has started to relax. The semilunar valves have closed, but the AV valves have not yet opened. And so there's no change in volume. This point here marks the opening of the AV valve. This point here represents the closing of the semilunar valves. So the heart is closed again. All the valves are closed, but the muscle is relaxing,
Right.
pressure is falling, but volume is not changing.
So in short, the isovolumetric points are when all the valves are closed, the blood can't go.
Yep.
Thank you.
So now I'm going to transition away from the heart and start to talk about pressure in the vascular system, blood pressure. This is related to the Wiggers diagram because this is ventricular pressure, but we don't measure ventricular pressure, we measure arterial pressure. So I need to transition out of the heart and into the vascular system. But before I do that, questions. And if you have questions that you want to ask in lab today, that's fine. We can pull up a Wiggers diagram and answer your questions in lab today, or anytime between now and Thursday, next Thursday. But I recommend feeling confident about your ability to interpret the Wiggers diagram because it is so important. You can be guaranteed that something about it will be on the test. So now let's talk about pressure, blood pressure. The heart maintains blood pressure. The heart and the vascular system maintain blood pressure. And it's the pressure that creates the flow to the various parts of the body, the brain, the heart itself, the liver, the kidneys, everything. So maintaining blood pressure is what the heart does. I mean, it also creates flow, but it's pressure that creates flow. So we need to understand blood pressure. So there's a simple equation. Pressure. Would not do that. Pressure is equal to flow times resistance. Those of you who are electrophysiologists or electrical physicists or whatever, those of you who know some electronics and physics will recognize this as Ohm's law for fluid flow instead of for electricity flow. V equals current times resistance, right? That's Ohm's law for electricity. Well, this is Ohm's law for fluid. So there's this is an important equation to know because I might ask you to use it during the answer of a question. Pressure is related to resistance, linearly. Flow is inversely related to resistance given a certain pressure. How did I figure that out? Well, rearranging, flow is equal to pressure divided by resistance. That's just a rearrangement of that. And so given a pressure, flow is inversely related to resistance. So being able to manipulate this simple equation and interpret it is part of your challenge. So now let's talk about pressure. In sort of specifically. This is generic. This is for, if you were a plumber, you know, working on the Richmond City water works, this equation would work. But we're not plumbers, we're cardiac scientists, or whatever you want to call us. So we talk about mean arterial pressure in terms of pressure. We talk about pressure, and typically we talk about the average pressure, and we're almost always talking about arterial, not venous pressure. Mean arterial pressure is equal to a flow term, and the flow term that we're almost always working with is cardiac output. The flow is what flows out of the heart. It's what the heart puts out. It's the cardiac output. Times resistance. The resistance that we talk about is the systemic vascular resistance. Some books call it total peripheral resistance. It's the same thing. It's the resistance to flow that your circulatory system, your vasculature, imposes on the flow. Okay, so I've unpacked, and there it is on the slide, cardiac output times systemic vascular resistance. Cardiac output, if I write it down here, can everybody see? Cardiac output is equal to the heart rate, the number of beats per minute, times the volume per beat, right? Beats per minute times volume per beat is going to give you volume per minute, which is a flow term, volume per minute. Is that clear? I did that too fast? Heart rate is in beats per minute. This is heart rate. And cardiac, stroke volume. So stroke volume is volume per beat. Stroke. This is engine terminology. The stroke of an engine. Some of the stroke is the same as volume. Stroke volume is volume per beat. So this is volume per beat. So you can see this is going to be volume per minute, and it's usually in milliliters per minute. A flow term, not a volume term, a flow per minute term, a volume per minute term, a flow term. Okay? So cardiac output is heart rate, beats per minute, times stroke volume, volume per beat. Pretty simple equations. So if we apply this here, so if I take these two equations and I merge them together, then I get mean arterial pressure is equal to heart rate times stroke volume, just exchange for cardiac output, times systemic vascular resistance. And this is an important equation to be able to memorize, but then to be able to apply. Don't just memorize it, know what it means. And know how you'd have to arrange it. If I said, well, you know, if stroke volume goes up, what happens to pressure? If pressure is, you know, maintained and heart rate goes up, so if heart rate goes up but pressure doesn't go up, what had to go down? That sort of thing. Okay? So here, these are some key equations. And it's not just the equations, it's the physiology that these equations represent. Physiologists love to turn their physiology into simple equations, and sometimes not so simple equations. And so it can be an annoying feature of a physiologist to say, well, why don't you just tell me what it means rather than writing some arithmetic? I'm a physiologist. I think equations are helpful because it condenses my understanding into a simple statement. But I'm always translating the equation into words. Rate times volume times resistance. It's just a sentence using mathematical terms. Questions about the key equations? Okay, so now let's get back to sort of real life, heart pressure. And here's a figure from your textbook. So you can see, here's cardiac output. Here's our equation. Cardiac output is stroke volume times heart rate. So we're focusing on cardiac output now, not mean arterial pressure. We're just focusing on the cardiac output part of it. And you can see what creates cardiac output, or what factors into cardiac output. Well, heart rate and stroke volume. Okay, that's simple enough. What controls heart rate and stroke volume? Well, now we can start to see things like the sympathetic nervous system increases heart rate. You saw this in lab last week. Epinephrine increases heart rate. The book puts epinephrine away from the sympathetic nervous system. If it were me, I would just include epinephrine, because you can see what epinephrine does, the sympathetic nervous system does. What epinephrine does, the sympathetic nervous system does. There. This arrow and this arrow. So epinephrine and norepinephrine from the sympathetic nervous system both trigger increases in heart rate and increases in stroke volume. You saw this when you applied epinephrine on the frog heart. Most of you saw an increase in heart rate and an increase in the force of contraction. That one's pretty straightforward, and we'll take that apart at the molecular level in the next slide. You'll also see that the parasympathetic nervous system, now we're talking about acetylcholine, in mammals, decreases the heart rate. So this is a negative, even though it's green, this would be a negative impact on the heart rate. You know that the acetylcholine caused a slowing of the heart rate. But in mammals, acetylcholine does not directly cause a decrease in contractility or stroke volume. We'll get into that detail. So if you say, well, the sympathetic nervous system increases stroke volume, but it has to come back down after a stimulus, what causes it to come back down? It's just sort of passive recovery from the stimulus. So we have active increases and decreases in heart rate, but we have only active increases in stroke volume and then sort of a passive recovery. Let's make more sense of this by looking at the molecular mechanisms. So this is a slide from your textbook. Again, I think your textbook is good in this chapter, and there's a copy on reserve here at the CST desk. So here is the receptor for epinephrine and norepinephrine on the surface membrane of all heart cells. Sinoatrial node, SA node, AV node, atrial muscle, ventricular muscle. All heart cells, all cardiac myocytes express the beta-adrenergic receptor, which is a GS. I mean, you could have looked at this, and if I hadn't just blown it, I could have asked you, what type of receptor is this? What type of G protein is this? You would have looked at, okay, it stimulates adenylyl cyclase, so it must be GS. This is a GS-coupled receptor. This is a GS-coupled receptor. This is GS. What is not shown here? GTP must be bound to this alpha in order to activate adenylyl cyclase. What does this arrow represent? Going back to the beginning of the class, of course. What's that?
Conformational change.
Conformational change and diffusion of the G protein alpha subunit from the beta adrenergic receptor to the adenylyl cyclase. In the membrane, diffusion of alpha in the membrane. Yeah, okay, so adenylyl cyclase is an enzyme, it's a membrane-associated enzyme, it's a transmembrane protein that catalyzes the conversion of ATP to cyclic AMP. Right? Cyclic AMP, this slide doesn't show it, but what does cyclic AMP bind to in this story? The XX of X. Cyclic AMP binds to the, somebody fill in the first one. I'm asking you to read my mind, I understand. What does cyclic AMP bind to?
PK.
Okay, that's the last word. It binds to the regulatory subunits. So there's the three words, regulatory subunits of pKa. And by binding to the regulatory subunits of pKa, it allows the catalytic subunits to work. So now we have a catalytic protein kinase A. And now we're going to see the mechanisms for increased contractility. Well, and increased heart rate. pKa stimulates voltage-gated calcium channels in all heart cells. So what does this do to the slow pacemaker potential? Does it increase the depolarization slope? Does it decrease the depolarization slope, or does it unchange it, leave it unchanged? It increases it, right? Because influx of calcium through voltage-gated calcium channels, your book calls it the dihydropyridine receptor, but you can call it the voltage-gated calcium channel. This calcium influx would depolarize this cell, and that's part of the slow depolarization of the SA node. Okay, so now let's stay in the heart rate area for a minute. What else does let's go back to, when I talked about this back last week, I guess. What else does pKa do to increase the heart rate besides activating voltage-gated calcium channels? There's something this slide is not showing as far as heart rate is concerned. It activates IH. It makes IH activity increase. IH is activated by both hyperpolarization and pKa. It's actually activated by hyperpolarization, cyclic AMP, and pKa. So all three of the things that are happening during the pacemaker potential, cyclic AMP directly and pKa indirectly, activate IH. Remember, IH is a sodium channel, sodium influx depolarization, increasing slow depolarization. So you could augment this to say in pacemaker cells, not contractile cells, IH is stimulated. What else? One more thing that allows pKa to increase the rate of the heart. One more thing. Some of you got it on the problems. I don't know, on the quiz. Or maybe it was the problems. It increases calcium influx. It increases sodium influx through IH, not shown. And it increases the rate of K-channel closing. And those are the mechanisms for the increase in heart rate. Now this slide is focusing on the increase of heart strength. So when we talk about strength, we're now talking about contractile cells, ventricular myocytes, not SA node, not AV node, atrial and ventricular myocytes, contractile. Okay, so let's go back to PKA. PKA activates calcium channels, voltage-gated calcium channels. Does that have an impact on contractile force? That's, many of you are nodding. Why? What's the mechanism? Okay, so calcium is binding to troponin, moving it out of the way, more cross bridges, more cross-bridge cycling, more force, faster force. What else? What does the influx of calcium through voltage-gated calcium channels do in addition to directly stimulating contraction? It binds to what? Oh, calmodulin. No, that's not what happens in the heart. Depolarization, yeah, we've already got that. It's not what I'm thinking of. Abby.
It induces the ryanodine receptor.
Ryanodine receptor.
Yeah, and then
Calcium-induced calcium release. More of this means more of this. This being calcium release from the sarcoplasmic reticulum. So now we have two mechanisms for the increase in calcium that cause movement of troponin and cross-bridge cycling. Calcium directly and calcium-induced calcium release. The protein kinase A also directly stimulates the calcium release channel, or the ryanodine receptor. So PKA activates the ryanodine receptor indirectly and directly. Is that clear? More calcium, a bigger rise in calcium during contraction. More troponin, more, there's the effect. What else? Your book says that PKA actually phosphorylates thin filaments and thick filaments, but that's a relatively minor effect. I wouldn't focus on 3 and 4 if I were you. I would focus on 1 and 2 for understanding why the beta adrenergic activation increases the force and velocity of contraction. And I would embellish this slide, if I were you, with the mechanisms for increasing the heart rate, because we talked about it, even though it's not in this slide. Okay, so those are the mechanisms for increasing the rise in calcium and the increase in contractile force. What is this supposed to be? What do you suppose this thing is? What happens to the calcium? How does the calcium get back into BSR? This is circa. So label your slides circa. This is the calcium ATPase that pumps calcium back into BSR. Does it pump it during systole? No, it's pumping the calcium during diastole to get rid of, to allow the muscle to relax. PKA, there's an arrow that's not well shown here. So this shows that calcium is pumped by circa, but PKA also activates circa. So draw another arrow here between PKA and circa, and it stimulates circa. So is that helpful? Yes, it's helpful, because if we're going to increase calcium out, we need to increase the rate of calcium in, because we need to relax as fast. If we're going to increase the contraction, we need to increase relaxation too, in order to have in order for the heart to refill before the next beat. So this is increasing contraction, and this is increasing the rate of relaxation by pumping calcium back out of the cytoplasm, allowing the cross-bridge cycles to not happen and the sarcomeres to elongate during relaxation. Question about that? So here's just a graph of, what are we looking at? We're looking at force, as a function of time. This is cardiac force. Here is the control, pumping. And here is the increase in force, both the increase in the rate and the peak, and the increase in the relaxation. Okay? So this slide is, I don't think I gave you this because it's so simple and follows so directly from the previous slide. So we have talked about how the sympathetic nervous system and epinephrine increase heart rate and increase force, which increases volume, right? If I contract more forcefully, I'm going to increase the amount of volume that's pumped by each pump, by each stroke of the pump. I forget what the next slide is. Oh, yeah. So I think I've unpacked this arrow, this arrow, this arrow, and this arrow. These 4 arrows have been explained in this flow chart. Any questions about those? What I'm going to do now is explain this arrow. A change in the end diastolic volume changes the stroke volume. How does that look? Well, here's the observation. This is what a physiologist discovered. His name is Starling. I think Starling was the physiologist who discovered this back in the beginning of the 20th century. If we, this is the data, these are the data. If we plot stroke volume as a function of end diastolic volume, remember what end diastolic volume is? The volume at the end of relaxation, just before contraction begins, end diastole. If we increase the volume at the end of diastole, we increase the stroke volume. Okay? Can we make sense of that? We can make sense of that if we think of this curve. So this is, this is force as a function of muscle length. And there is a perfect muscle length. At the perfect muscle length, the overlap between the myosin thick filaments and the actin thin filaments is perfect. And it allows for maximum generation of force when the cross-bridge cycle works. Right? So you should be able to see that. This is ideal for generating contraction. This, where the muscle is shorter than perfect, is less ideal. The things are bumping into each other and can't generate as much force. And out here, if we stretch it too much, there's less overlap between the thin filaments and the thick filaments, less ideal. So muscle has a perfect, an ideal length for contraction. And typically, we are operating around here, less than perfect. And if we increase the volume, remember if we increase the volume, we increase the stretch of the heart. If we increase the volume, we increase the stretch, we can get into a more perfect, a better position for generating force. So this is the explanation for this increase. Going from an imperfect overlap of the thin and thick filaments to a more perfect overlap of the thick and thin filaments of each cardiac heart cell. Now, what's your prediction? Knowing this graph, and now interpreting this graph in this context, what is your prediction if the end diastolic volume continues to increase, sort of past where they drew this curve? Michael, what do you say?
I'll eventually get.
It will eventually start coming down. So eventually, and this if the end diastolic volume gets too big, the force now is getting impaired because the force of contraction is getting impaired because we're now working in this region of the force versus muscle length chart, and that's heart failure. That's when people die. Okay, so now I'm going to transition into the vasculature more. Let's take a break for a couple minutes, and we're going to transition into the aorta and then the vascular system. So here, the purple line is aortic pressure. And you've been looking at it, you say, okay, ejection starts when ventricular pressure gets above aortic pressure, right there. And then, so some of you may have been looking at this purple line and trying to figure it out. And one thing that's mysterious about this purple line is, why does the aortic pressure stay high when the ventricular pressure has dropped to virtually nothing? Why does it stay high during diastole, when the heart is refilling? And well, you might know, you might have a sense. Michael, do you have a sense of why?
If the valve closes, is the pressure down?
So when the aortic valve closes, that's what generates the second sound.
Is your muscles are up
And the volume is low, and the pressure is falling. Those are all true statements, but that doesn't explain why this stays high even though this pressure is low. Michael?
Are there muscles around?
There are no muscles around the aorta, but there is something around the aorta. There is elasticity of the aorta. So this is from your textbook. This is supposed to be illustrating that when, so let's say this is, the picture says it's arteries, but let's just say this is the aorta and arteries. So during systole, what valve is this? The aortic valve. And so this pressure stretches the aorta and the arteries. It's got elasticity. It's got what physiologists call compliance. It is compliant. It stretches. So during systole, when the pressure is forcing fluid blood into the arteries stretch under the force of that pressure. And that's a simple equation, and I'm not going to ask you to use the compliance equation. I won't do that to you. But let's just understand it, intuitively. If this then stretches during systole, then during diastole, when there's no more blood being pumped, you know what happens if you let a rubber band go. It goes back to its original size. You know what happens when you let a balloon, blow up a balloon and let the air out of a balloon. It goes back to close to its original size. Same thing with the arteries. The recovery from the stretch maintains pressure in an elastic vessel. So the short answer to this question is elasticity or compliance of the arterial circulation, including the aorta. The pressure stays high because the aorta and the arteries were stretched, and now they are creating force by unstretching. And so it's sort of like an elastic pump. It's maintaining pressure, even though there's no actual pump. Okay? So that's the answer to that question. So, and I did that because we have to understand why, so this is pressure. You know from this chart that ventricular pressure goes way up and goes down to practically zero. Goes real low. End diastolic ventricular pressure is real low. But you also probably know that when we measure arterial pressure, it doesn't go to zero. It goes to some low value. So this is the wave of arterial pressure. This person has a blood pressure of 120/80. That's how you would read this. Systolic pressure is 120, diastolic pressure is 180. That's the arterial blood pressure of this person. And so this is systole, this is diastole. We use it just, we always do, the whole world does 120/80 for the naming of systolic, of arterial blood pressure. There is also variation in the pulmonary circulation, but the pressures are lower, systole, diastole. We don't measure this because, well, we don't typically measure this because it's much more invasive. But this represents the right systole, right ventricular systole, and this represents left ventricular systole. So this is what we measure. And we've got a clicker. Okay, let's do a clicker. Why are the pressures, I didn't give you clickers, but so I think there's one correct answer. Use your fingers. 1, 2, A, B, C, or D. Why are pressures in the pulmonary circulation so much lower than the systemic circulation? Going back. Why are pressures in the systolic circulation so much lower than the pressures in the pulmonary circulation? Show me your answer, please. Best answer is C. The right ventricle has less meat, has less mass, it generates less force than the left ventricle. Some of you might have chosen B, and that's just not true because the right ventricle is pumping out the same volume as the left ventricle. Otherwise, the blood is pooling somewhere, and it's not. Okay, so now let's talk about let's just do a clinical application. You know how, you've all had your blood pressure measured. They put a cuff around your brachial artery. That's what they're measuring. The brachial artery is in your upper arm, and they're measuring that is the arterial pressure they're measuring, brachial artery. And from that artery, they're inferring all of arterial pressure. So here, the green line is supposed to represent the wave of brachial artery pressure, going up and coming down, going up and coming down. Let's not worry about this little blip here. Diastole, systole, diastole, systole. Let's start over here. When they put the cuff on and they haven't pumped it up, there is no pressure, no external pressure on the brachial artery. And we're getting smooth flow through the brachial artery. And here's the key point. Smooth flow through the brachial artery is silent. You can't hear it. Then they pump it up to way up to like 200 millimeters of mercury. The pressure of the cuff, the pressure imposed by the cuff, is greater than the pressure imposed by the cuff is greater than the pressure imposed by the heart. The brachial artery has been squeezed shut. There is no flow. No flow is also silent. So there is no sound from the brachial artery. because there's no flow. And at the end, there's no sound from the brachial artery because there's smooth laminar flow. What I mean by smooth laminar flow is, imagine flow down a smooth gutter of water, a rain gutter. Smooth flow, it's flowing smoothly. But now imagine, if the pressure in the cuff falls below the pressure generated by the heart for at least a few fractions of a second, there's a point where the heart is going to be able to pump blood through this now not completely constricted brachial artery. It's constricted, but it's not completely constricted. A constricted artery has turbulent flow, and turbulent flow makes a sound. It's like a smooth stream is quiet. A stream with rocks and and little waterfalls makes a nice stream sound. Turbulent flow. And so as long as there is turbulent flow, so here the pressure has been released a little bit more, and there is a longer period of turbulent flow because there's a longer period, a longer time when heart pressure is greater than cuff pressure until it falls below, and then it becomes silent again. So what they're listening for, and what those machines are listening for, is turbulence, or the sound of turbulent flow through the brachial artery. And so the machine or the nurse or the physician marks the pressure at which they first start to hear sound, and that's the systolic pressure. And then they mark the sound, the pressure at which they stop hearing sound, and that's the diastolic pressure. You've all had this done. They may have even explained it to you, but that's how they turn the blood pressure cuff and the listening to the sound into pressures. And there's an art to this, and there's variation in this, not just person to person, but if I were to sit here and have my blood pressure taken by one person, and then go to a machine, just sit here and have a machine measure, there would be some variation because different people hear different, it's different. But that's how it's done. The machines are listening for a sound. The human being is listening for a sound, and they're listening for the end of the sound. Is that clear? We can do this in lab today. I've got cuffs, machines, and stethoscopes. We can try it in lab if you're interested. So I erased the equation, but you may remember, hopefully you remember, that when we talk about pressure, just pressure, we don't usually talk about pressure, systolic pressure and diastolic pressure. Remember, what am I talking about? I'm talking about my mean arterial pressure equation. Mean average arterial pressure is equal to heart rate times stroke volume times systemic vascular resistance. Did I get that right? Yeah. So how do we calculate mean arterial pressure? What we usually talk about is systolic pressure over diastolic pressure. 120 millimeters of mercury over 80 millimeters of mercury. In your case, it's probably closer to 120 over 60. Younger and healthier than the person on the screen. How do they calculate a mean if they want to use this equation? It's by this. It's not just averaging. It's not just averaging systolic pressure and diastolic pressure. Because we spend so much more time in diastole than we spend during systole, we weight it more. So again, you will not have to use this equation. I just want to point out that mean arterial pressure is weighted more towards diastole because we spend more time in diastole than in systole. Okay, so don't memorize this equation. So now let's continue our trip down the vascular system. And this is important because this is where blood pressure is controlled. Well, this is where resistance is controlled, right? So mean arterial pressure is controlled by the rate and the strength of the heart and by the resistance of the vascular system. And this is what we're trying to explain now. It's a branch system. Here's an artery that branches into 3 other arteries, that branches into, branching. So how does this work? Let's just work down the arterial system. It starts with the aorta. It starts with major arteries that you are responsible for knowing the names of some of them. The ones in the coloring book, the ones on the key concepts list. And then it breaks down into arteries that probably are not on your list, smaller ones that might not even have a name. And then, so here is a big, smaller, even smaller vessel having branched off of this artery. The transition from arteries to capillaries is caused by a series of little arteries called arterioles, none of which have names. But you have to know the name arteriole. So we go from arteries that have names to capillaries that don't have names, because there's a billion of them, to thousands, millions, tens of millions of arterioles, small arteries. Yeah.
What is the meaningful difference between a capillary and an arteriole? What does that cut off
The
from?
meaningful difference between a capillary and arteriole is capillaries are where oxygen and carbon dioxide exchange happens, nutrient and gas exchange happens in capillaries and not in arterioles. Then the capillaries start coming together into a series of microscopic veins called venules. Then veins that have names, that some of which you will have to learn. And then the vena cava, superior or inferior vena cava. Okay, so this slide I gave you so you can identify which ones, where you need to know. So let's go back to the systemic circulation. Here is the blood pressure in the brachial artery, say, going from 120 over 80. And then if we were to measure it in our arterioles, capillaries, venules, and veins, which we never do, but if we were to measure it, it might do something like this. This is a challenge question. Which part of the vasculature has the highest resistance? And let me remind you that pressure is equal to flow times resistance. And I'm going to help you out by saying the change in pressure is equal to the flow, which is more constant. Well, I'm just going to leave it like this. Flow times resistance. I'm going to turn it into a pressure differential. What part of the vasculature has the highest resistance? And we can do this as a clicker. A, if you say arteries, B, if you say arterioles, C, if capillaries, D, if it's veins and venules. Where is the resistance the highest? A, B, C, D. A, B, C, D. I forgot to bring it here. This is a challenge question. That is to say it's hard. The best answer, show me I want to see your best guess, your intuition. Okay, it's all over the place. The best answer is B. The arterioles is where the resistance is the highest. And how do I know that? It's because the slope, the change in pressure is highest. The change in pressure is highest in the arterioles. The change in pressure in arteries is almost nothing. The change in pressure in capillaries is lower. This slope is lower than this slope. So the arterioles is where resistance is high, and arterioles is where pressure, is where resistance is controlled. That's a key point. Write that one down. Arterioles is where systemic vascular resistance is controlled. How do we control resistance? By contracting or dilating arterioles, and we'll talk about that on Tuesday. What contracts an arteriole? What type of what? Read my mind. Kendra? Smooth muscle. Smooth muscle is what contracts arterioles. You should already be thinking, okay, what contracts smooth muscles? We got calcium, oh yeah, GQ coupled receptors, voltage gated calcium channels. We're going to do that again on Tuesday. So come prepared for that. But the point is, resistance is controlled by arterioles. And so arterioles, those tiny little microscopic vessels, have a role to play in blood pressure because they control one of the three terms of blood pressure. The heart, the sympathetic nervous system and the heart control heart rate. The sympathetic nervous system and the heart control stroke volume. But the sympathetic nervous system and the arterioles control resistance. Actually, it's not, and it's also the parasympathetic nervous system. The parasympathetic nerve, let's do the parasympathetic nervous system. Parasympathetic nervous system controls heart rate because it slows the heart rate. Acetylcholine slows the heart rate. It doesn't affect stroke volume directly, but it does decrease resistance by dilating vessels. Okay? So you can see why physiologists love to put an equation on there. They can apply physiologic principles to something as simple as a multiplying three terms and turn it into something that interprets and allows easy interpretation of actual physiologic result. So what is this is a figure from your textbook. This is supposed to represent a pressure reservoir. And these are supposed to represent the different places where blood goes, right? Because we have all that branching. So the blood goes, you know, so if this set of arterioles is dilated, this organ gets a lot of blood. If this set of arterioles is contracted, which we'll talk more about on Tuesday, this organ does not get a lot of blood. And in between, modestly, so these two are relatively contracted, no blood flow. These two are relatively dilated, lots of blood flow. This one is in between. And this is, where is this constriction? At arterioles, because that controls both where the pressure is and where the flow goes. So that's what happened here. Number 2 went way down. Number 3 went way up because of change of arteriolar constriction. Is that clear? So, and these two didn't change because these didn't change. So let's just finish this up with an example. You're sitting here, not exercising, but certain parts of your body are certainly getting blood, obviously. What part of your body gets blood? What part of your body gets blood whether you're exercising or not? Give me an example of a part you know, I think, maybe you know. What part of your body is going to get blood no matter whether you're exercising or not? Grant? Your brain. You need your brain whether you're exercising or not. Your brain gets blood when you're sleeping. Your brain is highly active during sleep. Your brain is highly active when you're learning. Your brain is highly active when you're moving. Your brain gets blood no matter, either is one of these two. It's not affected by whether you're exercising. What part of your body gets a lot more blood, goes from low blood to high blood flow when you're exercising? You know the answers to this too, Simon? Your muscles. Your muscles are going to demand more blood. So the arterioles that feed your muscles are going to dilate. By itself, what would that dilation do to your blood pressure? If all you did was dilate the blood vessels that feed your muscles and when you're starting a run, what would happen to your blood pressure? It would decrease. If we decrease resistance, we're going to decrease pressure. What would happen to the blood flow to the brain if all we did was dilate the arterioles that feed muscles? It would go down, because low pressure means low flow overall, which we don't do. We need, I mean, if you started to run and you deprive your brain of oxygen, of blood, you're going to faint, and that's not what you want to do when you want to run. So what goes hand in hand here? An increase in blood flow to the muscles. What part of your body gets a dramatic decrease in blood flow when you exercise? Your digestive tract. Another one. Your kidneys. At the start of an exercise, your skin gets less blood flow, and then as you have to start getting rid of heat, your skin gets more blood flow. So you may have had the experience when you start an exercise, you feel chilled for maybe a couple of minutes until you start to sweat. I don't know if you've I experience it all the time. When I just start a walk, I feel cold when I start a walk, and then I stop feeling cold, or else I build up body heat. Anyway, the point is, there's reciprocal control. If we're going to increase the systemic vascular, if we're going to increase the flow by decreasing resistance here, we're going to increase that resistance somewhere else in order to maintain a total systemic vascular resistance at approximately normal and a total mean arterial pressure at approximately normal. Right? Blood pressure does go up during exercise, but blood flow changes dramatically. Okay? That's the point. So muscles, liver gets a lot of blood because liver is going to produce the glucose from glycogen that your muscles need. So liver gets more blood. Muscles get more blood. Brain gets all the blood it needs all the time. Digestive tract and urinary system and skin, for at least a part, gets less blood in order to maintain resistance sort of stable. Okay, so I think that's the last slide. Yeah. So we're done for today, except for lab this afternoon. So come to lab this afternoon.